Hello dear friends, this is Dr. Bharatraj Kirambi. Today we will be discussing about the MCI Screening Test 2013 session, Set A questions. I have taken these from various websites like RXPG, Dr. Kamal KV's website, etc. Just don't keep mucking up the answers for the questions. It won't help you because it's basically some of the recall questions of the students. It's obviously what they think is right. It's better you see the questions and learn it from the reference textbook. You can get these questions in my blog right now. It's in clearmci.blogspot.in. You can also get a lot of free question papers by going and clicking here, download and practice papers. Okay, now let us start with the questions. I will be discussing the first two questions in detail. Hydatiform mole, 24-week size. What is the treatment? The treatment is going to be suction and evacuation. That's what is written as SNE in abbreviation. Obviously this is a very easy question and very often repeated topic. You should learn this hydatiform mole in detail because it will often be asked in DNB and NEET exams. Favorite questions of NBE. For preparing for obstetrics, I suggest you use the book written by Dr. Sakshi Arora because it contains most of the questions and the explanations are pretty good, except for a few places where I think you need to refer yourself to either Novak's gynecology or to standard textbooks for obstetrics. Okay, now you can get Dr. Sakshi Arora's book. You can purchase it directly from the store, or you can go here in Google Books and search for the book, and then you get this book here, Self-Assessment Review Obstetrics. It's an old version of Sakshi ma'am's book, but I think it'll do our job to learn the thing freely on the net. You go there and you click on the contents. You're going to see trophoblastic diseases including choriocarcinoma. That's chapter 8 in our book, and you click trophoblastic diseases, you will end up in this page. This is an older version of a book. You won't get some pages, but obviously you'll get other pages. Let us quickly go through the other questions that have been asked in H-mole. H-mole is actually a benign tumor with a malignant potential. It's a benign tumor of the chorion with a malignant potential. Okay, now going to the first question, PGI Chandigarh. You have multiple options in PGI Chandigarh. So let's see the first question. Complete mole is seen in humans only. Obviously, no one knows this, but wherever you see a placenta, I think you're supposed to see a tumor there. That is in placental site trophoblastic tumor. We'll come to that, but leave this option, controversial option. Trophoblastic proliferation, yes, that is the main pathology of H mole. The blastocyst contains two cells on its outer wall, that is in the cytotrophoblast and the syncytiotrophoblast, and then you're going to have trophoblastic proliferations, which is the main problem in H mole. And the syncytiotrophoblast keeps secreting beta HCG, so HCG is going to be the marker for H mole. There's going to be a hydropic degeneration, which means the villus pattern of the H mole is maintained, but the villus stroma is not maintained. You should either check in Google for the pictures. You'll find some pictures where you'll understand that the villus pattern is maintained and the villus stroma is edematous, and the edematous stroma is known as a hydropic degeneration. So the last option, villus pattern absent in H mole, is wrong option. Answer will be B and C. The villus pattern will be absent in one particular type of trophoblastic disease called the choriocarcinoma. There are four types of trophoblastic diseases: H mole, that is hydatiform mole, invasive mole, placental site trophoblastic tumor, and then you have your choriocarcinoma. Choriocarcinoma is a malignant version of the H mole, and in that particular trophoblastic disease, villus pattern is absent and there will be cellular atypia, which means that the cells are atypical. That's it. And then you can go on to the next question and then we'll come back. Chromosome, you need to know what is a complete hydatiform mole and a partial hydatiform mole. In a complete hydatiform mole, the chromosomal pattern is XX is true, which means in a complete hydatiform mole, it's only the paternal chromosomes which are duplicating. There is no maternal chromosome in a complete mole, so you're going to get a diploid number of chromosomes. That's a normal number, and the most common one is going to be XX 90% of the time. 10% it can be XY. It is of maternal origin, wrong. It is of paternal origin. There is enlarged ovarian cyst occurs, that is a true statement, because you have something called the theca lutein cyst. As you know, beta-HCG in the initial parts of the normal pregnancy supports the corpus luteum to secrete progesterone. Imagine if your syncytial trophoblast is secreting huge amounts of beta-HCG, it's going to create something called the theca lutein cyst in the ovary, and the cyst itself is actually a prognostic indicator, which means if you have bilateral theca lutein cyst, and if the theca lutein cyst is greater than 6 centimeters, by itself it is a risk factor for development of choriocarcinoma. And then it is common in developed countries is wrong. It's common in developing countries. Associated with preeclampsia is one of the important statements in specifically in females who are having hydatiform moles develop PIH before 24 weeks. That's an important thing to remember. Going to the next question, complete H moles are triploid, they're not triploid, they're diploid, and you have an increased beta HCG. That's true. 2% cases may convert to carcinoma. That is again true. See, I want to emphasize that complete hydatiform mole can go for choriocarcinoma more than a partial mole. The chances are more in complete mole. The last option, chances of malignant conversion is less than partial mole, is obviously false. The highest incidence of trophoblastic disease is seen in Asian population. And then there is one more important risk factor which needs you to use your memory, by which I mean everything else can have a logical deduction, but few things you need to memorize, like blood group A individual, blood group A women married to blood group O individuals is actually a risk factor. Blood group women A married to blood group O men is a risk factor. And then you have a risk factor wherein you have deficient proteins, folic acid and keratin is again a risk factor for developing hydatiform mole. These things no one can deduce logically, and these are the things they might ask you in exams. The next question, follow-up of a patient of H mole is done by, it's called serum beta HCG monitoring. Actually it's called serial HCG monitoring, wherein you keep monitoring the HCG serially after 4 to 6 weeks and again after 10 weeks. And snowstorm appearance is a classical one which is seen in hydatiform mole, and obviously if you read the explanations given in the book and in any standard textbook, you will find that snowstorm appearance is actually got by a low resolution ultrasound in the olden days. Nowadays you don't get snowstorm appearance classically, and you're getting the snowstorm appearance because there is actually no amniotic fluid present, and the uterus kind of feels doughy on palpation, and you check out the ultrasound, you're going to get a snowstorm appearance. But I'll tell you something that they might ask you. They might ask you, how do you find an ultrasound nowadays, and how would you detect a partial mole? And I can just go to Google and search for ultrasound features of partial mole, and what you're going to get is something like this, where you're going to see a placental site which is attached to the multiple cystic spaces. Any of these images is good. Multiple cystic spaces. This is very classical of a partial mole. Okay, snowstorm opacity is seen in H mole once again, and then after this, prophylactic chemotherapy is indicated after evacuation of H mole in all except, and if you're going to the first option, initial urine HCG is greater than 40,000, and after 6 weeks of evacuation, initial increase in HCG titer 24,000. After 10 weeks of evacuation, metastasis and nulliparous lady. The obvious answer is nulliparous lady. Nulliparous lady is not even a risk factor for H mole, it's multiparous lady. Parity greater than 3, and more importantly, age is more important than the parity as a risk factor. Age more than 39 is a risk factor. You will find this in the WHO prognostic indicators better than any of these things. It's easy to memorize, it's easy to logically deduce other three, whereas nulliparous lady is not a risk factor at all. Treatment of theca lutein cyst is a very good question. This is an indirect question. The treatment of theca lutein cyst in hydatidiform mole. The theca lutein cyst, you should understand, is because of the hydatidiform mole, and if you treat the hydatidiform mole, the theca lutein cyst is going to disappear. So the treatment of choice for hydatidiform mole is suction and evacuation, which is basically the same question you got in the MCI screening test 2013. They will ask you what is the treatment of choice for any mole, irrespective of the age of the irrespective of the gestational age of the particular pregnancy. It will be suction and evacuation, and you have to decide what you have to do. For example, let's see the next question. 40-year patient, P4+2 female, having been diagnosed with HMO. What did you do now? Now you're not going to do a suction evacuation. Obviously now you're going to do a total hysterectomy, because she has already completed her family size and you don't need to preserve her uterus anymore. So you need to decide what you have to choose depending on the situations. A case of gestational trophoblastic neoplasia belongs to a high-risk group if the disease develops after. This is a very tricky question. It's as I told you, the table that you have to look into, the WHO prognostic indicators, and it's after full-term pregnancy. See, there are some various prognostic indicators that you should know. If the lady develops a H mole, if a lady develops a trophoblastic disease, if a lady develops a trophoblastic disease after a full-term pregnancy, she's a high-risk category. And if she has taken chemotherapy only after, there's a delay of 12 months before her pregnancy and her start of chemotherapy of 12 months, that's a high risk. And if the initial presentation of trophoblastic disease during her gestation had a very high HCG titer, that again is a risk factor. And then blood group, as I told you, is a risk factor. Age greater than 39 is a risk factor. So you should have a look at these. It's there in all standard textbooks, and it's there even in her book, Dr. Sakshi Arora's book. I think you should, if you can continue with these questions. The only thing I'd like to emphasize is you should know a few things, like, for example, the common site of question number 15, the common site of metastasis in choriocarcinoma is to the lungs. That's 80% of the time. The other one is to the vaginal mets is quite common in choriocarcinoma, and typically they'll have a purplish color and they bleed on touch. That's how they frame the questions, and that's important to know. So I think you should just go through the remaining part of the questions by yourself, and then you will find the answers here. And I think you can even find the WHO prognostic indicators here. Yes, this is the WHO prognostic indicators for gestation trophoblastic disease. As you can see, a term pregnancy carries a score of 2, so that's a risk. And then blood group A carries a score of a higher risk, and the initial HCG level, pre-treatment HCG levels high, carries a very high risk. The pregnancy, the chemotherapy initiation interval between the after the pregnancy, more than 12 months, is again a risk factor. So okay, these are the few things that you need to know about H mole. There are lots of other questions, but we'll go through if we get another question on H mole. Basically, I want you to remember that they will ask you a question, treatment of choice, and then you have to say it's suction and evacuation. And then they will ask you the drug of choice, and then you have to say it's methotrexate. And if they're really intelligent, they're going to confuse you, giving you options of methotrexate indication for ectopic pregnancy and for choriocarcinoma, by which I mean you do know that there are specific indications for giving methotrexate in ectopic pregnancy. They would give you that in the options, and they will also give you an option for giving methotrexate in choriocarcinoma. In choriocarcinoma, you need to remember that if there's any metastasis, you need to give methotrexate. Whereas in ectopic pregnancy, you need to give methotrexate only if the ectopic sac is less than 4 centimeters, there's absence of fetal heart sounds, and there is and also if the initial HCG titer is quite low, less than 10,000, less than 2,000 carries a very, very good effect of methotrexate. And then there's one more trick question here. They will ask you What is the drug given to a choriocarcinoma patient who is suffering from jaundice? And please do not answer methotrexate there, because methotrexate is contraindicated in any patient with liver dysfunction. There you give actinomycin D. Okay, now we'll just go on to the next question. Appendicular mass conservative. The student has written appendicular mass conservative and elective surgery with a wrong spelling. Obviously, this question, I think they are referring to the Ochsner-Sheren regimen, and this one is quite important as well. If you go to surgery, the classical book I think you should follow should be Amit Ashish surgery, or it can also be Rachna Chaurasia surgery book, and you should have Schwartz and Sabistan's reviews as your guide and the main book as your guide. And there are various questions on appendix chapter. Let's just go through a few of the most common questions. I'll tell you very quickly what to remember. First MCQ, in McBurney's incision, it's the iliohypogastric nerve which is damaged. And then you should have another question like, what is the most common parasite associated? The most common parasite associated with appendix is Oxyuris vermicularis. That's the most common one. There are many things which are implicated, but this is a very common parasite which is implicated. And please do not answer as Caris, because the lumen size is so small that the worm cannot actually enter the appendix to cause any problem there, whereas this pinworm or Oxyuris vermicularis can enter. And then they will ask you what, no one is going to ask you the most common site. Everyone knows it's retrocecal. They are not going to ask you the most common site. Then they might ask you different questions based on the signs which are present in appendicitis, like Schwartz sign, obturator sign, and Rolfing sign. Rolfing sign is pressing in the left iliac fossa and you get a pain in the right iliac fossa. And there's one particular AIMS question where they have actually asked you they have actually described the Schwartz test. Like, for example, the patient feels pain on hyperextension of the hip joint. That is a classical Schwartz test, and the position of the appendix is retrocecal. They might ask you questions like, in carcinoid, I think it's important for you to know that the recent Schwartz edition in carcinoid has given that if there is a carcinoid tumor in appendix, you should classify it as classically less than 1 to 2 centimeters and more than 2 centimeters. If it's less than 1 centimeter, all you need to do is an appendicectomy. If it's more than 2 centimeters, you need to do a right hemicolectomy. If it's between 1 and 2 centimeters, you have to know if the tumor is present at the tip of the appendix or at the midpoint of the appendix. If it's at the tip or the midpoint, then you can just do an appendicectomy. If it's present at the base, where it's in close relation to the cecum, then you have to do a right hemicolectomy. These are some new things which have come up. If you're really interested in bridging the gap between MCI screening test and PG, you should have a look at prophylactic indications of appendicectomy.